tumors, and pericardial diseases. Hopefully, at the end of this lecture, I would be able to give you a good insight and understanding about these topics, and will you be able to apply the concepts into practice. So let's go to shock and cardiac arrest. Shock is a clinical condition of organ dysfunction resulting from an imbalance between cellular oxygen supply and demand. It can be a result of multitude of heterogeneous disease processes, and organ dysfunction during early stages may be reversible. That's why early detection of your patient going on shock can um, be easily reversible. However, it can proceed to an irreversible pace and death from multi-system organ dysfunction if left untreated. That's why it's very imperative to identify the type of shock and initiate appropriate therapy. Here is a simple illustration on how your oxygen delivery to the different tissues can be examined. No? So oxygen delivery is affected by two factors. You have your cardiac output and your arterial oxygen content. So this is actually the product of your cardiac output and your arterial oxygen content. As we all know, when you have cardiac output, this is my favorite question with our residents. No, how do you get blood pressure? Blood pressure is equal to cardiac output times peripheral resistance, and cardiac output can be um, divided in or can be withdrawn from this equation: stroke volume times heart rate. We all know that the stroke volume is affected by three major factors. You have your preload, the afterload, and your contractility. Here, your preload is being determined by your myocardial fiber length before it contracts. The afterload is the force against which the ventricle must contract, and your contractility is the ability of your left ventricle to contract independent of your preload and your afterload. On the other hand, your arterial oxygen content can be derived from the oxygen saturation and your hemoglobin concentration as shown by the equation here. So here is what happened to your tissues if you have persistent hypoxia. No? When you have hypoxia, you have damage to your cells and to your tissues. When you have significant hypoxia, that would lead now to your anaerobic glycolysis leading to lactic acidosis. And also, there will be production of your vasodilator substances like that of your prostaglandin and your kinins that would eventually decrease your cardiac output and fall in your blood pressure. Now, hypoxia can also lead to capillary endothelial damage. So once you have capillary endothelial damage, you have increased in your cell permeability, losing now fluid to tissue spaces. This is what you call third spacing, and eventually it would decrease your cardiac output and low in your blood pressure, leading now to your tissue hypoxia and vital organ damage. Here are stages of shock. Initially, your body would try to compensate, or your pre-shock. Your normal circulatory compensatory mechanism eventually cause full recovery without help from outside therapy. What are these neurohormonal mechanisms? You have increase in heart rate, increase in your RR, no? And eventually, if your compensatory mechanisms fail, Your patient now would develop decompensated shock, or your second stage of shock. Your body utilizes a variety of physiologic responses to counteract the initial insult and attempts to reestablish the adequate perfusion and oxygen delivery. Your patient transitions into true shock with evidence of organ dysfunction once your compensatory responses are overwhelmed. Then eventually, if your body, if the shock is already decompensated, it would now lead to an irreversible shock wherein mortality is very high, no, or there will be an organ dysfunction that is permanent, very difficult actually to reverse. Some or most of the time, it's irreversible, as mentioned here. Often progresses to multi-system organ dysfunction. Here are the types of shock. No, most common is your distributive. Under distributive shock, you have there your septic shock, which is the most common cause of shock under distributive shock. You also have pancreatitis, severe burns, anaphylactic shock, neurogenic shock, endocrine shock, and adrenal crisis. Other types of shock is your cardiogenic shock, wherein if you have acute coronary syndrome or your myocardial infarction, presence of your myocarditis, arrhythmia, and valvular issues, wherein your heart muscle cannot perform its function in terms of your contractility that can cause cardiogenic shock. Obstructive shock also, like for instance, if you have tension pneumothorax, cardiac tamponade, constrictive pericarditis, pulmonary embolism, and aortic dissection. And lastly, you have the hypovolemic shock, wherein if your patient has hemorrhagic problems like caused by your trauma, your GI bleed, ruptured ectopic pregnancy, that can cause a lot of hemorrhage and causing now your hypovolemic shock. Significant GI losses, burns, polyuria caused by your DKA or diabetic ketoacidosis, and your diabetes insipidus can have this type of shock, your hypovolemic shock, if not addressed properly. Explaining further your major shock types. In obstructive shock, it occurs when blood cannot get where it needs to go, like your pulmonary embolism and tension pneumothorax, as mentioned earlier. Cardiogenic shock would occur when the heart is weakened, damaged, and can no longer pump blood effectively. Distributive shock occurs when blood vessels become leaky and reduce the amount of blood that reaches the organs, like that of your septic shock, your anaphylactic shock, and your severe burns. Hypovolemic shock occurs when there is not enough fluid or blood volume circulating through the body. For example, if your patient gets dehydrated, has hemorrhage, vomiting, diarrhea, and burns. Okay, let's go with this type of shock one by one. Distributive shock, a condition of reduced oxygen delivery where the primary physiologic disturbance is a reduction in systemic vascular resistance. So in other words, in distributive shock, there is vasodilatation in the peripheral vessels, causing now some hypotension. There will be increase in your heart rate as a compensatory response to increase or maintain the cardiac output. The most common type of distributive shock, as I mentioned to you earlier, is your sepsis. Others are shown here. In cardiogenic shock, there is a reduced oxygen delivery related to a reduction in your cardiac output owing now to a primary cardiac problem. There is increase in your systemic vascular resistance as a compensatory mechanism, and it's seen in the following condition. Hypovolemic shock, there will be reduction in your preload. Hemorrhage is the most common cause. There will be external bleeding secondary to your trauma. Internal bleeding, most commonly from the upper or the lower gastrointestinal tracts. There is also non-hemorrhagic processes that can cause hypovolemic shock if you have profound emesis, diarrhea, um, renal losses like that of osmotic diuresis associated with diabetic ketoacidosis or your DI. No? Skin loss from severe burns, inflammatory conditions such as Stevens Johnson. Obstructive shock can be seen if there will be reduction in your oxygen delivery related to reduced cardiac output due to extracardiac pulmonary vascular or mechanical processes impairing now your blood flow. This can impede your venous return to the heart. For example, if you have tension pneumothorax, cardiac tamponade, restrictive pericarditis. There is an obstruction in your cardiac outflow. For instance, if you have a pulmonary embolism, air embolism, fat embolism, and if there will be some dissection, this can reduce your blood pressure, all of this type of shock. Here's the summary of the hemodynamic characteristics of the major types of shock. As you can see here, the types of shock, the distributive, cardiac output is increased, and you have your CBP or your central venous pressure, your pulmonary capillary wedge pressure, and your SVR or your systemic vascular resistance, which is very low. Now, in cardiogenic shock, the CBP is high. No, the wedge is also high, and the SVR is high. However, there's not enough cardiac output in cardiogenic shock. In obstructive shock, there is neutral effect on your wedge, but cardiac output is also decreased, but your CVP and your SVR is high. In hypovolemic shock, you have a very low CVP, wedge pressure, and your cardiac output. Hence, you have increase in your systemic vascular resistance as a compensatory mechanism. Evaluation of patients with shock is very important. As we all know, history again is very essential in the determination of patients with shock, because it can somehow identify immediately what type of shock we are dealing with once we have a good history. Like for instance, your patient had or suffered from acute myocardial infarction, hence most likely you would think of a cardiogenic shock. The history also is very important to see if there will be some overlap in the type of shock. For instance, very common in the ICU, you have an MI patient or acute coronary syndrome patient superimposed now with pneumonia that develop sepsis in the process. Hence, you have two types of shock there, your cardiogenic shock and your distributive form of shock. That's why history is very important. Likewise, your PE can also be very helpful in determining what type of shock, as you can see earlier about the hemodynamic changes that I've shown you earlier with your CBP, your wedge, your systemic vascular resistance, and your cardiac output. And of course, diagnostic testing also is very important to evaluate what type of shock we are dealing with. Simple echo can rule out or rule in some problem with your obstructive shock. And also with the cardiogenic shock, because we can also see from the echo if your ejection fraction or your ability of your left ventricle to pump blood to the different parts of your body. Confirming the presence of shock, if there will be new organ dysfunction, and to identify specific etiology or to determine the type of shock present using now these tools, your history, physical examination, and diagnostic testing. Now, let's go to your history. Obtaining a concise focus history. When focal symptoms are reported, it is important to determine whether the symptom is related to the primary process causing shock or as a result of your inadequate oxygen delivery for cellular metabolic needs. Your ancillary information from family or friends accompanying the patient, emergency medical services personnel, or nursing facility should be obtained as well. The most easily identified new organ dysfunction from the history is the presence of a newly altered mental status or a decrease in your urine output. You ask the patient if they're still, or the relative in that example, if the patient is still urinating, are they following commands or are they answering you appropriately? So these are some of the questions you might want to know from your informant regarding this. And of course, charting now your information that you've gathered from your patient. So these are just common history that you might want to you might get from your informant. In septic shock, there is presence of fever and history suggesting a focal site of infection. In anaphylactic shock, there is history of pruritus, no hives or dyspnea, edema, no, and exposure to common allergens. In cardiogenic shock, there is an onset of exertional chest discomfort, palpitations with syncope or presyncope. In hypovolemic shock, sometimes the history is glaring with trauma, blunt or penetrating, or there is a GI bleed. No, in obstructive shock, there will be tearing chest um, or back pain, maybe caused by your aortic dissection, and you have asymmetric leg swelling, things like that. Now, very important that you have some important information that you might get if you know how to do good history taking. Your PE can assist you in the identification of shock. It can add insight into what type of shock is present. There will be hypotension or decrease in your mean arterial pressure. You have to evaluate the patient's current blood pressure in relation to the patient's baseline blood pressure. Okay, for instance, if your patient is known hypertensive and he is on medication, and yet you know that the usual blood pressure of your patient is 140, but now when he's in the hospital, then you get the blood pressure and the result is, for example, 160. You know that's a relative hypotension in relation to the normal blood pressure of your patient. That's why it's very important that you want to get the normal or usual blood pressure of your patient. And to observe hemodynamic trends over the short time intervals. If your patient has tachycardia and you have tachypnea. Physical exam, you have to see first if there is hypotension. Then these are signs of tissue hypoperfusion. You have altered mental state, mottled and clammy skin. There is oliguria or decrease in your urine output. There is tachycardia, elevated blood lactate in your labs. No, so you have to identify if these signs of hypoperfusion are present or absent in your patients. In terms of your initial laboratory exam or evaluation, you have to get the lactate, as mentioned earlier. If your patient, um, if your patient had to shift from anaerobic respiration, lactate, you would expect that the lactate is very high. And here, you might want also to have your renal, your liver, your cardiac enzymes as part of your initial laboratory examination, and a lot of laboratory tests you can see from this slide. ECG, it is an essential part of the evaluation of your patient with shock. You might want to see if there will be bradycardia or tachycardia, ST segment elevation, your classic pulmonary embolism, S1Q3T3 pattern, and reduced voltage in the presence of your electrical alternance as seen in your pericardial tamponade. X-ray is a very simple tool, yet it can give you enough information and can help you differentiate the types of shock. Because if you have, for example, if your patient has pneumonia, no, or has pulmonary congestion or edema, has pericardial effusion, as you can see that in your X-ray, or presence of your pneumothorax, peripheral wedge shape, opacity indicating your pulmonary infarction, large pulmonary artery, no, and there will be some regional vascular oliguria. This can be seen in X-ray. Right now, because of the advent of technology, point of care ultrasound is very, very now common, especially in tertiary hospitals. Now, the point of care ultrasound, you would now give you an idea that you are dealing with something else if you know how to use that properly. That's why me personally, we train our students, our residents, our fellows on how to use that. This is a very powerful tool in assessing patients, especially in the emergency room or in the ICUs, no? And a life-threatening condition can be um, detected if you know how to use your ultrasound. We call that point of care ultrasound. No, because this is non-invasive and very timely. No, in terms of knowing the result, especially if you know how to handle it or how to do it. Initial treatment of shock, initiate treatment for circulatory shock simultaneous with efforts to elucidate shock etiology. Your goal is to know the etiology so you can reverse the underlying physiologic abnormality, which could cause the hypoperfusion, that reducing your oxygen delivery. Ensure adequate intravenous access for aggressive volume resuscitation that is required for patients with distributive or hypovolemic shock. And me, as an intensivist, I usually advocate doctors or their attending doctors to insert a central line or a central venous catheter that can provide you therapy with your vasopressors and inotropes, that can also give you an accurate hemodynamic monitoring, because you can just insert swan guns or a central line. No, we call that central venous catheter, especially if your patient would go to the emergency department and there are a lot of medications competing with one IV line. No? Kasi isa lang yun that you don't have yet central line. So if you anticipate a toxic patient, no, from the ER or even from the floors, you might want to suggest to insert a central line for better monitoring and for better access for a lot of medications to your toxic patient. And also, we insert Foley catheter, as shown in your right upper portion of your screen, urinary catheter placement to permit hourly assessment of your renal function as another potential indication of your adequacy of resuscitation. Next is volume resuscitation. This is the initial form of resuscitation to all forms of shock. No, you might want to see the volume status of your patient. So initial volume resuscitation has the aim of restoring your tissue perfusion and is crucial to optimal shock therapy. A minimum of your 30 ml per kilogram, as recommended by the surviving sepsis guidelines. Begin with the crystalloid, no, yung mga plain LR or plain NSS. Pack red blood cells is warranted, especially if your patient um, is known to have trauma, the need for continued volume place replacement must be frequently reassessed. So, again, do not forget to resuscitate your patient with volume first. This is very common tool that we use in the ICU to see if your patient is volume responsive or not. We call that a passive leg raise test or Trendelenburg position. It predicts responsiveness to additional intravenous fluid, provides the patient with an endogenous volume bolus, especially if your patient has an arterial line wherein you can immediately see the response of your blood pressure, resuscitation with your volume. The patient's head becomes horizontal and the legs are extended at the 45 degrees angle as shown here. In terms of your vasopressors, now initiated if your intravascular volume status has been optimized with volume resuscitation, but hypotension and inadequate tissue perfusion persist. It must be tailored to the primary physiologic disturbance like that of your distributive shock since it aims to increase your systemic vascular resistance. Your norepinephrine is the first choice vasopressor. Now, in the sepsis guidelines, vasopressin is safe and has a role as a second agent for hypotension in septic shock. We usually give your vasopressin if your norepinephrine already reached up to zero point 0.3 to zero point 0.5. Now, this is to avoid or minimize your tachyarrhythmia brought about by your norepinephrine. Since your norepinephrine is a form of catecholamines with alpha and beta adrenergic receptors, no? So your vasopressin, not a catecholamine, this can be used as a second line for patient with septic shock. For cardiogenic shock, usually if your patient would come to the emergency department with hypotension, you have to increase first the blood pressure. Now with your norepinephrine, then once you have BP of 90, at least 90, now your dobutamine is your first line agent to augment the contractility because your dobutamine is a synthetic catecholamine with primarily beta-mediated effects and with the minimal impact on your alpha adrenergic receptors. Beta 1 being used to increase your inotropy or your capacity of your heart muscles to contract. Your B2 effect should be it could vasodilate the vessels with decrease in your afterload. Uh, can be used with norepinephrine, as mentioned earlier, with mixed distributive and cardiogenic shock. Oxygenation and ventilation support, you have to give supplemental oxygen and titrate to maintain your SpO2 of 92 to 95%. Administration of your antibiotics, especially if you're dealing with septic shock, you have to give your broad spectrum antibiotics after obtaining appropriate cultures. The inability to obtain culture should not delay the start of your treatment. No? Every hour of delay in your antibiotic administration is associated with an increase in your mortality. That's why high suspicion of your patient, especially if you're dealing with septic shock, we have what we call the an hour bundle, wherein within an hour you should initiate treatment and at the same time investigate what's causing the sepsis in an hour. Okay, so specific causes of septic of shock, no, requiring tailored intervention. So distributive shock secondary to anaphylaxis, you have to remove the inciting allergen, administration of your epinephrine, then vascular support with intravenous fluid resuscitation and your vasopressors. Adrenal insufficiency, replacement with your intravenous stress dose steroids. If we have cardiogenic shock with arrhythmia, we have to give or do advanced cardiac life support algorithms the placement of your artificial pacemaker. So, if you have acute ischemic events, your goal is to revascularize, or the use of your temporary mechanical circulatory support. If you have valve dysfunction, surgery may be considered. And also, if you have hypovolemic shock due to hemorrhage, surgical intervention in trauma or endoscopic or interventional radiology procedures in the case of a GI source or blood loss. Obstructive shock, like tension pneumothorax, you have to do immediate decompression. In pulmonary embolism, thrombolytic rather therapy or surgical removal of the clot uh, might be the option for in treating your obstructive shock. Of course, if you have dissection, surgical intervention should be done. Okay, we're done now with the shock. No, so let's go to your cardiovascular collapse, arrest, and sudden cardiac death. When you say cardiac collapse, this is a sudden loss of effective circulation due to cardiac and or peripheral vascular factors that may reverse spontaneously or require interventions. May result in cerebral hypoperfusion and loss of consciousness. Shown here, if you have neurocardiogenic syncope, presence of your ventricular tachyarrhythmias, severe bradycardia, severely depressed myocardial contractility, massive MI, pulmonary embolism, myocardial rupture from with cardiac tamponade or papillary muscle rupture with torrential mitral regurgitation. These can cause actually some cerebral hypoperfusion and loss of consciousness, and can have cardiovascular collapse. Cardiac arrest occurs in the absence of spontaneous resolution. How about sudden cardiac arrest? This is an abrupt cessation of your cardiac function, resulting in loss of effective circulation that may be reversible by prompt emergency medical intervention, but will lead to death in its absence. It is mostly occur outside the hospital. Sudden cardiac death, the death that occurs after sudden cardiac arrest. Sudden unexpected death attributed to cardiac arrest, which if witnessed occurs within 1 hour of symptom onset. It comprises 50% of all cardiac deaths. Your coronary heart disease for majority of sudden cardiac death can also be the first clinical expression of previously undiagnosed heart disease. Kaya nga tridor ang sakit sa puso. These are the common causes of your sudden cardiac death. And of course, your coronary heart disease still the number one reason for having sudden cardiac death. Then you have here your cardiomyopathies, then your inherited arrhythmia syndrome, then valvular heart disease, and others, your idiopathic ventricular fibrillation. And of course, as you can see here, not aside from the coronary heart disease, you have to remember that it varies what type of or what causes the death. Now, as you go along from age of sudden cardiac death onset, no, because we have the inherited arrhythmia, no, common among young people, no, especially with the athletes. Okay, in terms of the causes of your cardiovascular collapse and sudden cardiac arrest, you have here the different cardiac causes. Now, of course, as I mentioned, your coronary artery disease is the most common cause of your sudden cardiac arrest. If you have atherosclerosis, coronary spasm, and some congenital anomalies. Next is you have your cardiomyopathies, your congenital heart disease, valvular heart problems. Then you have the arrhythmia, without structural heart disease, like that of your long QT, your Brugada, your CPVT, and the like. We also have non-cardiac causes of your cardiovascular collapse, like pulmonary embolism, your stroke, no, your tension pneumothorax, or other um, diseases, non-cardiac causes of your cardiovascular collapse. Okay. Now, in terms of the management of your cardiac arrest, the um, advanced life support team had this chain of survival for us to uh, increase the survival rate for patient who just had sudden cardiac death. Early recognition is very important. That's why, as you can see, no, the Philippine Heart Association would really want to have that the Philippines is CPR ready. No, because if we want to um, increase the survival rate of those patients who had cardiac arrest, we have to know how to do the CPR. That early CPR, you can actually buy time, no, as we would deal later on with the ROSC, no, if we achieve some ROSC or restore return of rather return of spontaneous circulation. So here, early defib, no, that's why um, the mandate of our government that you should have defibrillators everywhere, no? So at least we can um, help restart the heart if something happens, to your patient. And lately, we saw that in the Philippines, especially here in Metro Manila, now because there are 66 million travelers. That's what they uh, noted for 2025. Oh, so right now they would want to have um, in the highways, no, they would want to uh, teach all people, especially our security guards, etc., because from the data of Department of Transportation, no, they saw that usually here in Manila, no, two cardiac arrests every month. They saw that um, the need to really teach our reinforcer to do CPR. So because of that statistic, so once they know how to do early CPR, when we teach them, and if the defibrillators are everywhere, that can increase the survival rate, leading now to your return of spontaneous circulation to restore the quality of life. Okay, that's how we manage your cardiac arrest. BFib or pulseless VTAC. No, you have to do chest compression. This is actually from your ACLS because your VFib is an arrest rhythm. No, you have four arrest rhythm: your ventricular fibrillation, your pulseless ventricular tachycardia, your asystole, and your pulseless electrical activity. So when you have ventricular fibrillation or pulseless ventricular tachycardia, you might want to do immediate chest compression. If your defibrillator is available, of course, you have to defib the patient just to restart the electrical activity. If there is no ROSC, then go back again to your compression. No, of course, you have to do, if your rhythm is shockable, you have to do and shock the patient. So this algorithm is very important, and we highlighted this during your advanced life support training. You know? ACLS. So here is your bradyarrhythmia or asystole. Now, in terms of the management for CPR, if your patient is not yet intubated, you have to intubate and ready for an IV access because that's where we would want to give your epinephrine. Okay, confirm if this is systole because if it's not, then you have to do a proper management. Now, because if it is systole, of course, you have to continue your CPR. Very important here, guys. I might give this to your exam. Identify and treat the reversible causes. You have the 5 H's and 5 5 P's, 5 T's rather. So you 5H, you have your hypoxia, hyper or hypokalemia, uh, hydrogen ions or severe acidosis. You have your hypothermia, no? You have your hypovolemia, hypoxia, your tamponade, pneumothorax, hypothermia, no? Pulmonary embolism, drug overdose, hyperkalemia, or massive acute MI. So you have to really identify, the if there are reversible causes that you might want to address to help survival higher now in this particular scenario. For bradycardic patient, you might want to give atropine, 1 milligram IV. The maximum dose of your atropine is 3 milligrams. Or if still having a pharmacologic management for the symptomatic bradycardia, you might want to um, start pacing the patient either with external or pacing wires. Okay. Treatments for your post-cardiac arrest syndrome, because if your patient had cardiac arrest, no, we know that there are no circulation that goes to your brain, your heart, your lung, your liver and gut, and your kidneys. That's why all of these organs, no, we might want to address the post-arrest, no, management to these organs because here specific treatment pertaining to specific organ system. Now we might want actually to address them. No, patient who had the brain trauma and that led the patient to coma, you have to do temperature management, targeted temperature management. Then, if your patient had shock, no, and had acute myocardial infarction, you might want to do early coronary angiogram, no, to do coronary intervention. So, if you have respiratory failure, liver failure, and renal failure, all of these patients should go to the ICU for intensive care monitoring. Okay, how about your ICD or your implantable cardioverter defibrillator, or in patients with ischemic heart disease to prevent sudden cardiac death? Patients with ischemic heart disease with a meaningful survival of 1 year expected, you go to this algorithm. If you want to have primary prevention of your sudden cardiac death, then you have to answer the following questions. All of the following would apply. You have low left ventricular ejection fraction due to ischemic heart disease. More than if you had post myocardial infarction of more than 40 days, and if you did bypass or stenting, you have to see if your patient had more than 90 days post revascularization. If your LV ejection fraction is less than 35% and your patient is NIHA class 2 or 3 heart failure despite guided directed therapy, yes, you might want to do ICD. If, on the other hand, your LVEF is less than 30%, yet your patient is NIHA class 1, No, despite guideline-directed management and therapy, you can have the ICD for primary prevention. Now, let's go to the secondary prevention of sudden cardiac death using your ICD. If any of the following applies, no, if you have sudden cardiac arrest due to ventricular tachycardia or ventricular fibrillation, hemodynamically unstable, uh, ventricular tachycardia, or you have stable ventricular tachycardia, not due to reversible causes though, then you have unexplained syncope plus inducible sustained monomorphic VT on electrophysiology study, then you might want to give secondary prevention of your sudden cardiac death. Okay? Remind you that ICDs are expensive. Now, it depends on the brand. It can have, it would play from 300 to 1 million now for the ICDs. So preventing sudden cardiac death in general population, you have to identify their lifestyle, advise them to avoid smoking, maintain a healthy body weight, to do moderate exercise, and of course, choosing the Mediterranean type dietary pattern. Okay, I think we'll go now to the last topic of your pericardial diseases. Now, going back to basics, anatomically, the normal pericardium is a double-layered sac of the visceral pericardium and your parietal pericardium. The visceral pericardium is composed of a monolayer of mesothelial cells and collagen and elastin fibers adherent to the epicardial surface of the heart. The parietal pericardium, on the other hand, is the thicker fibrous sac surrounding the heart, normally about 2 millimeters thick, and is largely acellular and contains your collagen and your elastic fibers. Although it is often the parietal pericardium that is typically referred to as the pericardium, most diseases state simultaneously involving both layers. As we know, normally there is 15 to 50 ml of normal buffering fluid within the pericardial space. The pericardium restrains the four cardiac chambers within a relatively confined volume and space within the thorax. Because of this constraint, the total volume of the four cardiac chambers is limited, and changes in the volume of one chamber must, by necessity, be reflected in an opposite change in volume of another chamber. Okay? And the linking of the intracardiac volumes will be the basis for the changes in the pathologies we will be tackling later. So while the removal has no obvious negative consequences, the pericardium does function to maintain a relatively constant position of the heart in the thorax and provides a barrier to infection. So this lifted from your Harrison's functions of your pericardium. It has mechanical and it has immunologic, vasomotor function, fibrinolytic, and vehicle for drug delivery and gene therapy. Okay, so these are some of the functions of your pericardium. So very important, actually. So these are classification of your pericarditis. As you can see here, the etiologic classification. There are a lot of diseases that can affect your pericardium. Notice here that you have infectious pericarditis, and there are also non-infectious causes of your pericarditis. Okay? And also with pericarditis presumably related to autoimmunity. Acute pericarditis, very common in terms of mimicking your chest pain. Okay? The chest pain is characterized as severe retrosternal and or left precordial, referred to the neck, arms, or your left shoulder. pleuritic pain, consequently accompany your pleural inflammation. Steady radiates to the trapezius ridge or into either arm, may be intensified by lying supine and relieved by sitting up and leaning forward as shown in your figure here. In acute pericarditis, there is a presence of your pericardial friction rub, or this is an audible at some point in the illness in about 85% of the patient, described as rasping, scratching, or grating, and it is observed in end expiration with the patient upright and leaning forward. In acute pericarditis, there is a very noticeable ECG findings that you can see here that can mimic your ST elevation MI. Now, but in acute pericarditis, there is a widespread ST segment elevation. Um, which is concave comparing to your ST elevation, which is convex. And here, there is a depression now of your PR segment, now, as shown here in your AVR. There is a depression of your PR segment now. So this is the classic findings for your acute pericarditis. Also, there is electrical alternance for large pericardial effusion. As you can see here in your EKG in lead 2, no, you have alternating low voltage um, low voltage complexes seen in your lead 2. How to diagnose? Your echo is still the best diagnostic tool for assessing the physiologic and hemodynamic effects of your pericardial effusion. This is very simple, sensitive, and specific, but non-invasive tool. Of course, you might want to request for CT scan or MRI as well. Treatment, usually you have to do bed rest, and if the pain actually is severe, you might want to give anti-inflammatory medications like aspirin, your NSAIDs. Now, with the following doses, it should be administered along with your gastric protection, and you have to continue this treatment for 1 to 2 weeks and then tapered over several weeks. Me, in my practice, I usually give colchicine, no, and it should be given for at least 3 months. Okay, let's go now to cardiac tamponade. Cardiac tamponade is a life-threatening condition caused by fluid accumulation in the pericardial sac that compresses the cardiac chambers and inhibits your normal filling chambers, resulting now to a reduce in your cardiac output. And this is an emergency, guys. Remember that there is 3 Ds in your tamponade. You have distant heart sounds, decreased arterial BP, and distended neck veins. This is your Beck's triad. Remember that not everyone with cardiac tamponade will show all 3 signs of your Beck's triad. Sometimes it would be just associated with an echo findings, now buildup of fluid or blood or air in the pericardial sac, resulting now to heart compression. Other signs that might appear in your cardiac tamponade, early signs is your tachycardia and shortness of breath. Okay, there's also paradoxical pulse, an important clue to the presence of your cardiac tamponade. There's a greater than normal inspiratory decline in your systolic arterial pressure. This also occurs in approximately 1/3 of patients with constrictive pericarditis, hypovolemic shock, or patients with COPD. Diagnosis of your tamponade, there is late diastolic inward motion or collapse of the right ventricular free wall and the right atrium. Okay, so nagsiswing, there's swinging heart. Note that the large pericardial effusion, and the marked change in position of the heart, it can cause electrical alternance, as shown in the ECG earlier. Treatment, you have to do pericardiocentesis, no, pericardial drain, or do cardiectomy. So it depends on the causes of your pericardial effusion or the presence of your tamponade. Now, sometimes longer um, duration of putting up your window or a pigtail. No, if you know that there will be recurrence or fast recurrence of the fluid in your heart, you might want to do pericardial drain rather than doing pericardiocentesis alone, because we know that it can be recurrent. For example, if you have an active TB pericarditis, or if you have um, if you're dealing with cancer now that spreads in the heart, you might want to um, deal with the longer or more permanent treatment, like putting up pericardial drain and or pericardiectomy. So let's deal with chronic pericardial effusion. These are common causes of your chronic pericardial effusion: patient with tuberculosis, myxedema, patient with neoplasm or cancer, uh, lupus, no, systemic lupus erythematosus, rheumatoid arthritis, mycotic infections, radiation therapy to the chest, chylopericardium, and the treatment still with pericardiocentesis, especially if it is acute, then pericardiectomy, if with recurrence, and intrapericardial instillation of sclerosing agents. Okay, chronic pericarditis, as you can see here, with the comparing to normal heart with the pericardial constriction, you know that this is a chronic inflammatory process, and this results when healing of an acute fibrinous or a serofibrinous pericarditis, or the resorption of a chronic pericardial effusion followed by obliteration of your pericardial cavity with the formation of granulation tissue. It forms a rigid scar or shell encasing the heart, which may become calcified. Now causes inability of the ventricles to fill, owing to the limitations imposed by the rigid, thickened pericardium, that can mimic some form of obstructive form of shock if this will continue. Clinical findings, you have weakness, fatigue, no, or there's some non-specific symptoms that you can see with their chronic pericarditis. There will be exertional dyspnea and orthopnea, Kussmaul sign, or your paradoxical rise in your jugular venous during inspiration. You have also paradoxical pulse, congestive hepatomegaly, presence of effusion, splenomegaly. You have the broad bent sign, or there is an apical pulse reduction and may retract in systole, or your pericardial knock, early third heart sound. You have a sharp, high-pitched sound during early diastole in your left sternal border. Okay? In terms of imaging, there's no absolute sensitive and specific echocardiographic finding. The actual detection of a thickened pericardium is difficult, but if you do cardiac CT and MRI, it provides a higher resolution and accurate assessment of direct pericardial anatomy, as shown here. Now, treatment: pericardial resection is the only definitive treatment of constrictive pericarditis and should be as complete as possible. So comparing now your patient with tamponade, no, with your pericarditis, as you can see here, in terms of pulsus paradoxus, you have your tamponade and your effusive constrictive pericarditis. your presence of prominent X descent, no, in tamponade and restrictive cardiomyopathy. You can't have third heart sound in your tamponade. Low voltage is very common, no, and presence of your electrical alternance. Okay, so these are some of the distinguishing characteristics of your cardiac tamponade from your constrictive pericarditis and some similar clinical disorders like your RV myocardial infarction. Now, let's go to the last topic, your cardiac tumors. Cardiac tumors can be broadly classified into those that arise primarily in the heart and those that reflect metastatic disease from a distant primary source. Primary cardiac tumors can be further divided into those that are pathologically benign and those that are malignant. Primary cardiac tumors are relatively uncommon, whereas secondary involvement of the heart or pericardium occurs in as many as 20% of patients with end-stage metastatic cancer. Cardiac tumors may present with a variety of symptoms. Many patients are asymptomatic at the time of their diagnosis. Echo is usually the initial imaging modality used to evaluate your cardiac tumors. So as you can see here, um, the different metastatic tumors coming from the different organ systems. So the location of the tumor can somehow give you an idea what type of cancer you are dealing with. So as you can see here, if you have lymphoma and melanoma, you can have it at the apical portion of your heart. Now, if you have myxoma, you can just see that in atria, no? Specifically in your left atrium. So these are very important information that you can have if you're dealing with cardiac tumors. Okay, benign primary cardiac tumors, symptoms are very non-specific. As I mentioned earlier, sometimes they don't have any symptoms at all prior to the discovery of the disease. No? But if they have, these are the following symptoms that you can observe: chest pain, syncope, heart failure, murmurs, arrhythmias, presence of effusion, pericardial tamponade, and your embolic phenomena. Myxoma is the most common adult primary benign cardiac tumors, one-third to one-half of all cardiac tumors. Most are sporadic, 10% familial, common in the third through sixth decade of life. It has female predilection, presence of smooth, globular, or grape cluster-like appearance on echocardiogram. 75% is located in the left atrium, and it is attached by a pedicle to the interatrial septum near the fossa ovalis, less frequently in the right atrium or in ventricles. So this is your atrial myxoma. Okay, can you hear that? Myxoma has a variable presentation, may be sudden in onset or positional in nature, owing to the effects of gravity on tumor position. As you can hear, now there's a low pitch sound or your tumor plop during early or mid diastole. Results from the impact of the tumor against the mitral valve or your ventricular wall. Peripheral or pulmonary embolic phenomenon resulting from embolization of tumor fragments or tumor-associated thrombus. Constitutional signs and symptoms, you have fever, weight loss, cachexia, malaise, arthralgias, no? Rash, digital clubbing, and sometimes you have your Raynaud's phenomenon. How about LA myxoma? Two-dimensional and three-dimensional transthoracic and or transesophageal echo are useful in the diagnosis of cardiac myxoma and allow for assessment of tumor size and determination of the size or the site of the tumor attachment, both of which are important considerations in planning of surgical excision. In left atrial myxoma, here in letter A, you can see a parasternal long axis view, B mode. B, you have M mode, view showing the mass prolapsing through the mitral valve into the left ventricle in diastole. Letter C, the one in your left lower, you have an apical four-chamber view. Then your D, you have the transmitral gradients, or there is mitral stenosis, as shown by your color Doppler, no? With peak and mean gradient of 23 and 12 millimeters mercury. Okay, so there is a LA myxoma here. Treatment, you have surgical excision using your cardiopulmonary bypass. There's recurrence, no, in 12 to 22% of familial cases and 1 to 2% of sporadic cases. This is RA myxoma. As you can see here, there's a huge mass in the RA now, impeding now your blood flow going to the circulation. Okay, cardiac lipoma. It may grow as large as 15 centimeters, present as an abnormality of the cardiac silhouette on chest X-ray, encapsulated collections of benign fat cells that tend to occur in subepicardial or subendocardial locations. Can be located anywhere in the heart. Your right atrium is the most common location for your cardiac lipoma. May grow into the pericardial space, does not embolize compared to your liposarcomas, and does not cause ventricular arrhythmias compared to your fibromas. Differential diagnosis, you have lipomatous hypertrophy of your interatrial septum, should be resected if they produce symptoms owing to mechanical interference with cardiac function, arrhythmias, or conduction disturbances. You have your papillary fibroelastoma. This is the second most common primary benign neoplasm. It comprises 10% of all primary tumors. It is common in older patients. Most common tumor of the cardiac valves, aortic valve, 44%, mitral, 35%, your tricuspid, 15%, and your pulmonic valve, 8%, and rarely on the other endocardial surfaces. Located in the mid portion of the valve, single, small, usually approximately 1 to 1.5 centimeters, and they're solitary. The shape, they may be round, oval, or frond-like in shape, homogeneous in texture, so clinically silent but carry increased embolic risk. This is an example of your papillary fibroelastoma. Okay. How about rhabdomyoma? Rhabdomyoma is most common primary cardiac neoplasm among children. Solid intramyocardial lesions with striated myocyte fibers occur in the left ventricle. Your mechanical obstruction to blood flow, mimicking your valvular stenosis, congestive heart failure, restrictive or hypertrophic cardiomyopathy, or pericardial constriction. It occurs in 90% as multiple tumors in children with tuberous sclerosis. Most regress completely or partially spontaneously. Okay, this is the baseline echo before, then 4 years after treatment. As you can see, nawala yung rhabdomyoma. Fibroma, second most common pediatric cardiac neoplasm, single universally ventricular in location, and it's open calcified. Consists of solid tumors containing fibroblasts, do not spontaneously regress, may grow to a size that obliterates the heart chamber, interferes with valvular function, or causes arrhythmia, as shown here. Okay, but malignant primary cardiac tumors, Almost all malignant primary cardiac tumors are sarcomas, which may be of several histologic types. Angiosarcomas are the most common type in adults, whereas your rhabdomyosarcomas are the most common type in children. Your cardiac malignancies appear to infiltrate the tissues, disrupting your normal anatomic planes and invade or obliterate contiguous structures. The heart often appears tethered and relatively immobile without its normal translational motion. Contrast perfusion imaging, you have malignant tumors and other vascular structures often demonstrate hyperenhancement. Thrombi and other avascular masses show less contrast uptake. The echo demonstration of an invasive cardiac tumor should suggest the possibility of your metastatic disease. The exact location and extent of cardiac malignancy must be thoroughly assessed to determine whether resection might be possible. Okay, here's your angiosarcoma. In general, sarcomas are characterized by rapid progression that culminates in the patient's death within weeks to months from the time of presentation as a result of hemodynamic compromise, local invasion, or distant metastases. Sarcomas commonly involve the right side of the heart, are rapidly growing, frequently invade the pericardial space, and may obstruct the cardiac chambers or venae cava. Sarcomas also may occur on the left side of the heart and may be mistaken for myxomas. The optimal therapy for cardiac sarcoma is complete resection, often with neoadjuvant and post-op chemotherapy. Metastatic tumors of the heart. Okay. So, mode of spread to the heart, we have direct tumor invasion or lymphangitic spread or hematogenous spread. Most commonly encountered with metastatic extension to the heart, you have the breast cancer, lung cancer, and your melanoma. So, metastatic tumors to the heart, source and cardiac manifestations. As stated here, your original source, if you have lung, there is a direct extension, often via your pulmonary veins or your effusion, common breast, hematogenous or lymphatic spread, lymphoma, not through lymphatic spread, GI, variable manifestations, your melanoma, intracardiac or myocardial involvement, your renal cell carcinoma through IVC to RA to RV, then sometimes it confuses us with thrombus. Carcinoid, your tricuspid and your pulmonic valve thickening.
Another example of a metastatic melanoma that's involving the apex of the LV. You can see this over here. This patient, you would have it from the fluid context of a melanoma with intracardiac. This is another example of a metastatic melanoma that's involving the apex of the LV. You can see this over here. This patient, you would have it from the fluid context.
Okay, your melanoma has highest predilection to metastasize to pericardium and or myocardium as mentioned earlier. Your intracardiac masses are frequently seen as a manifestation of your malignant melanoma. Figure in the left is an example of your melanoma that has metastasized to the left ventricular apex. Although the appearance of the mass is similar to that of a thrombus, preserved apical contractility makes a thrombus unlikely and should suggest the possibility of alternative diagnosis. Figure to the right is taken from another patient with melanoma metastatic to the right ventricular apex. Okay? Carcinoid tumors, it affects your tricuspid valve. That's the predominant site of your involvement. Now, fibrosis, smooth muscle proliferation, and endocardial thickening. Valves appear thickened, retracted, and immobile that could result now to severe tricuspid regurgitation. IVC extension of metastatic tumor, very common. We have renal hepatocellular carcinoma, uterine, And if you have pulmonary veins, you from lungs, breast, and thyroid. Okay, so these are secondary um, cause of your tumor. Now, from direct extension, your hematogenous spread, from your venous spread, and lymphatic spread. Treatment of metastatic tumor, usually it's palliative, controlling your symptoms, and of course, treatment of the primary tumor. So, symptomatic malignant pericardial effusion should be drained by your pericardiosynthesis. Okay, I think we've covered the whole topic of shock and cardiac arrest, your pericardial diseases, and your cardiac tumors. Again, thank you for listening, and I'll be doing your exam, and majority of the exam questions will be coming from this lecture. Thank you.
Thank you po, Doc.